Our next talk, this clip, anybody here Downton Abbey fans? Yeah, a few, okay. You may or may not remember this scene. I kind of had forgotten it until I saw this clip. I think it's appropriate to the topic at hand, which you'll find out about in a minute. So I'm just going to show this, and you guys can see what you think.
Oh, don't you enjoy a good fight?
I'm not sure I do, really.
My mother-in-law has a certain myopia when it comes to anyone else's point of view.
On the contrary, I have a clarity of vision that allows me to resist a housemaid's trap of sentimentality.
Your enthusiasm is getting the better of your manners.
Can't we stop this beastly row?
How I wish we could.
Because I'm so sorry.
Thomas, please left side.
Give me napkins.
I'll call the ambulance. Keep him warm. Take my coat.
What is it?
His ulcer has burst.
What? Will he be all right?
We must get him to hospital as quickly as we can.
I'm here, darling. Don't worry, I'm here.
If this is it, just know I have loved you very, very much.
This isn't it, darling. We won't let this be it.
Some water.
No water. Just keep him steady until the ambulance arrives. All right.
Is he very bad?
I've rung for the ambulance. It'll be here at any moment. Miss Baxter, Anna, fetch their ladyship's coats. Don't forget Lady Edith.
And what about me, Mr. Carson?
You might put together some things that could be useful, but hurry, there's no time to lose.
I can't believe it.
Life is short, death is sure. That is all we know.
There is a man who's been shaken to the roots of his soul. Everything he based his life on has proved mortal after all. We've no time for philosophy, Mrs. Patmore. What can we do to help? Let's send up some coffee.
Only the English, right? What can we do to help? Let's send up some coffee. I thought it should have been tea, but coffee. Anyway, so that's the clip. The talk is on ulcers or GI bleeds, I should say, upper GI bleeds. Dr. Shannon Goodall will be talking about PPIs should be initiated in all upper GI bleeds prior to endoscopy, something which I think most people kind of routinely do when they get an upper GI bleed. And when you're doing the admitting orders, everybody just orders a PPI, it's kind of just one of those checkbox things. So we'll see if we should actually be doing that.
Thank you all for coming. I'm Shannon, one of the medical interns. Today I'm going to discuss PPIs used before endoscopy in upper GI bleeds. So upper GI bleeds are considered any clinically significant bleeding from above the ligament of Treitz in the GI tract. Symptoms are usually include hematemesis, coffee ground emesis, melena, or in some cases hematochezia. The most common causes are gastric or duodenal ulcers, esophagitis or gastritis, and then varices and Mallory-Weiss tears are also reasonably common causes as well. And then there's some more rare causes lower down. The incidence is about 80 to 150 per 100,000 people per year, and the mortality remains around 2 to 15% of patients. So the rationale for using PPI therapy in these patients who present with upper GI bleeds is that since the PPI inhibits the hydrogen potassium ATPase in the parietal cells in the stomach, it decreases gastric acid secretion, which increases the intragastric pH. In vitro studies have been done that have shown that having a lower gastric pH impairs platelet aggregation, prolongs clot formation time, and impairs clot stability. So logically, by increasing the intragastric pH, we can help promote hemostasis in these patients. And that's why we basically start PPIs on anyone who presents with symptoms of upper GI bleeds. So the first study I could find on this topic was published in 1992. It was a randomized controlled trial that compared omeprazole to placebo. They looked at 1,147 patients, and of their outcomes, there was no significant difference in the rate of needing transfusion, the rate of rebleeding, the rate of surgery, or of needing surgical intervention, the rate of death, or basically the mortality rate. The only finding they did that was significant was that endoscopic signs of bleeding at index endoscopy were decreased in the patients receiving PPI. Otherwise, there was really no effect of receiving PPI before endoscopy. So they had concluded that based on this data, there's no justification for using acid suppression in these patients at first presentation. Since then, there's been a few meta-analyses done. This one is for a Cochrane database that was initially published in 2010 and then was updated earlier this year. So they actually found no new studies since the original one in 2010, but they looked at 6 randomized controlled trials in unselected patients with upper GI bleed. So it doesn't matter what their etiology was if they had a suspicion of one etiology versus another. And they compared PPIs to either placebo, H2 blockers, or no treatment. So the outcomes they looked at were mortality, rebleeding, need for surgery or transcatheter ablation, the proportion of patients with stigmata of recent hemorrhage at index endoscopy, so that includes active bleeding, an adherent clot, or a non-bleeding visible vessel. And the final outcome was need for endoscopic hemostatic treatment. So this slide shows the forest plots for the first 3 outcomes. So mortality is in the top left, rebleeding is in the bottom left, and on the right side is need for surgery. So as you can see, there's no significant difference for any of these patient-centered outcomes for the PPI group versus no PPI group. For their other outcomes that are less patient-centered, on the left has the results for stigmata of recent hemorrhage. There was one study that only reported that finding in patients who were found to have peptic ulcer disease. So the top left shows the findings for stigmata of recent hemorrhage, not including the study that was narrowed to just patients with peptic ulcer disease, and the bottom does include that study. So when that study was included, there was a significant difference between the PPI group and the control, with a decrease in stigmata of recent hemorrhage at endoscopy when that study was included. On the right shows endoscopic hemostatic treatment at index endoscopy, and in that study, the PPI group had a decreased need for hemostatic therapies. So based on these studies, they then did a subgroup analysis to see if we looked at only the patients that were found to have peptic ulcer bleeding, if there would be improvement in the patient-centered outcomes. And they found that there was still no difference in mortality, rebleeding, or surgery in patients with peptic ulcer disease who received PPI therapy prior to endoscopy. So far things haven't been super convincing. I looked for some other reviews. There were multiple non-systematic reviews and editorials that have been published, and basically all of the editorials just discussed that one meta-analysis and analyzed that one meta-analysis. There were 2 other systematic reviews. The Healy 2015 study was only published in abstract form, included 4 randomized controlled trials, and didn't list what trials they were. There was also a systematic review included as part of the National Institute for Health and Care Excellence Guidelines, which is a UK group that writes healthcare-related guidelines. They included 4 randomized controlled trials, all of which were in the meta-analysis that we just looked at. And the outcomes of these 2 studies were, again, that there's no difference in mortality, rebleeding, or need for surgery in patients receiving PPI prior to endoscopy. So since there wasn't very much evidence in the literature, I reviewed some of the published guidelines, and despite the fact that all of the guidelines I could find referred to that same meta-analysis, they came up with different conclusions. So the National Institute for Health and Clinical Excellence and the Asia Pacific Working Group both recommend no PPI before endoscopy because there's no impact on patient outcomes. The one guideline that did recommend PPI therapy, this bottom set of guidelines for non-variceal upper GI bleeding in Korea, they weighed more heavily the advantage of decreasing stigmata of recent hemorrhage and need for endoscopic hemostatic therapy. So they recommended continuing to use PPIs prior to endoscopy, even though they acknowledge that there's no impact on patient-centered outcomes. And then these 3 guidelines so the American College of Gastroenterology and the International Consensus Group and the European Society of Gastroenterology endoscopy give a very vague recommendation that you can consider using PPIs. The only real advice they give on what to consider is that they say any patients who might have endoscopy delayed or won't be able to get endoscopy should receive PPIs. Otherwise, they give no real criteria as to what you should be considering. They just kind of leave it up to the physician, and they all acknowledge that there's no impact on patient-centered outcomes. So at this stage, I was wondering, okay, but who cares? If we're going to start PPIs in everyone after endoscopy anyways, what's the harm in a few extra doses by starting it beforehand? So I reviewed some of the literature for PPIs after endoscopy. So one meta-analysis of randomized controlled trials looked at PPIs after endoscopy and peptic ulcer disease. They found that there was a reduced incidence of rebleeding and need for surgery in patients who were started on PPIs after endoscopy. But there was no impact on mortality. They then did a subgroup analysis, and interestingly, there was decreased mortality in studies that were based in Asian countries. And when they looked at the non-Asian countries and did a sensitivity analysis, there was actually a signal for increased mortality in those patients that were started on PPIs after. They didn't really give a great explanation as to what they thought might be the cause, and they didn't list the causes of death in those patients. So it was hard to interpret exactly what was happening there and why that was increased. Regardless, the American College of Gastroenterology and other guidelines, for the most part, recommend PPIs after endoscopy only in patients with peptic ulcer disease. So American College of Gastroenterology basically says, if you do endoscopy and you see peptic ulcer disease, continue the PPI. If there's another cause of bleeding, you should stop the PPI and not continue treating with that. For the other causes of GI bleeding outside of peptic ulcer disease, there's evidence for using PPIs in patients with erosive disease, so either gastritis or esophagitis. For varices, there's some mixed recommendations. Some people recommend it after banding therapy, but the vast majority of meta-analyses and guidelines I read suggested no PPIs in patients after banding therapy or with presenting after a variceal bleed. So at this stage, basically, up to like 30% of our patients aren't going to be or shouldn't be started on a PPI after endoscopy, and there's no benefit to starting them before. So it's difficult to tease out exactly what the benefit of continuing to use PPIs both before and after are when some patients won't need to be exposed to these medications at all, particularly in the setting of, as we use PPIs more and more often, we're identifying some risks of the therapy. They are generally very well tolerated, but there has recently been reports of an increased risk of C. diff and pneumonia with short-term use. So some of the C. diff studies look, and just within a few days of starting therapy, there's an increased risk of developing C. diff in hospitalized patients who are on PPIs. And for pneumonia, they also looked at short-term use of PPIs. So they found the highest risk was within the first 7 days of therapy. And this study looked at within the first month. Longer term use actually didn't have the same increase in risk of pneumonia. So initiating PPI therapy actually has some more associated risks than we thought. Still reasonably low, but a risk nonetheless. And then there's some longer term risks with PPI therapy. So particularly in patients with cirrhosis or patients with variceal bleeds who are not going to benefit from PPI therapy anyways, are at increased risk of hepatic encephalopathy, spontaneous bacterial peritonitis, and other enteric infections like Salmonella and Campylobacter. There's also a risk of interstitial nephritis and other causes of kidney failure. There's fundic gland polyps, and then vitamin B12 and hypomagnesemia have also been reported in patients on long-term PPIs. So, like with anything, we need to be weighing the risks and benefits of the therapies that we provide. And given that there's really no there's no benefit to using these therapies, even if these risks are reasonably low, we really need to factor in both sides of the coin. In terms of us being aware of our possible implicit biases, I could only find one study based in the US that broke down the etiology of GI bleeds based on the cause. So in this one study that has the one caveat of they had a much higher incidence of variceal bleeds than I've seen in other studies. They found that non-Hispanic whites their most common cause of upper GI bleed was peptic ulcer disease and varices. In Hispanic populations, the most common cause of upper GI bleed was varices. And in Black patients, the most common cause of upper GI bleed was peptic ulcer disease. More importantly, I think we need to be aware of making sure all patients are receiving the same care. So there was a study that showed that Hispanic patients had increased wait times for upper GI bleed presentations in the emergency room. And then another study that showed that Black patients were less likely to receive EGD within 1 day of admission. And one of the most consistent recommendations in all of the guidelines is that patients have an EGD within 1 day. So we just need to keep this in mind and make sure all of our patients are receiving equal and equitable care. So in conclusion, pre-endoscopy PPI has no impact on patient-centered outcomes, including mortality, rebleeding, or need for surgery. The one situation in which they do have an advantage is if endoscopy is unavailable or will be delayed. Also important to keep in mind that not all patients should be started on PPI after endoscopy either. So the added risk of starting PPI in these patients when there are risks of the therapy is something that we need to consider when we're weighing the benefits versus risks. And given that there don't seem to be any real benefits of this therapy, I think we should really give some more thought to our use of this therapy that we use so consistently.
Okay, so like I said, I think it's common for people when they're doing their admitting orders on upper GI bleed just to throw them on a PPI before the endoscopy is even done, before you know the etiology. And you know, I've been guilty of this. Probably all of us have. So I think maybe we should re-examine our practice here. But does anybody have any comments or questions? Dr. Bordowski, I was waiting for you to say something.
I missed, how was delayed endoscopy defined?
The studies I looked at a number of different time points. So less than 12 hours actually had some risk of increased mortality. And the ideal window was kind of between 12 to 24 hours. And then in terms of their recommendation of delayed endoscopy, they never really defined it. It was just sort of if you weren't going to be able to access it in a reasonable amount of time, with the goal being less than 24 hours.
I see, because that could be, you know, if someone comes in at 6 a.m. with their GI bleed, they're likely to get scoped, at least in this hospital during the week, that, or even on the weekend that day. So it wouldn't, you know, especially depending on what your pretest probability was, that seems reasonable. Very nice presentation.
Yeah, I think that it's generally 24 hours is kind of considered, more than 24 hours, I think is usually considered delayed, or somewhere between 12 and 24 hours. And I think the vast majority of time patients here get scoped within that period. Any other comments or questions? No? Okay, well, it's time to vote. Is it a myth? PPI should be initiated in all upper GI bleeds prior to endoscopy. Many people think that's true, that we should be doing that. How many people think it's plausible? How many think that this is a myth and it's busted? Okay, again, unanimous. All right, so double tap. Double tap.